Thank you. So today's recipe for health training is on food insecurity training. It's targeted for medical assistants and prescribers without MAs, but we certainly welcome any prescriber with an MA to be here, especially as you all think about team-based care. My name is Stephen Chen. I'm the Chief Medical Officer for All in Alameda County. This is using virtual technology. We will be recording this session. Please turn your devices to airplane mode and close other windows just to avoid distractions. And please be prepared to use the chat to communicate. Activate your camera is so helpful to me to not just be speaking into the void of cyberspace. So we're going to jump in the overview. Today's session for the next 55 minutes, we will be covering 4 sections. A brief review of the model.
Good, you? I'm good. I'm calling regarding Dr. Shredar's forms, current rise. I guess
How do I mute everyone? Corey, can you help with muting? Okay, fantastic. So the brief review of the recipe for health model. Food insecurity, the what, the why, the how. Key workflows also should be reviewed because we did this January 19th, but I think repetition can be helpful. And then certainly this is the key piece, the art of asking about food insecurity so you're not triggering patients. So we're gonna jump in with the recipe for model. Hopefully you all have this drilled into your brain now. This is the recipe for health sandwich where we are in the middle as that protein, that fish, that burger, the veggie burger, whatever, working with the health centers to grow this program and operationalize it. We provide the additional support across the county with a food pharmacy, and it's a recipe for health pharmacy that you'll have access to and your patients will, and then the behavioral pharmacy group medical visits. So the 2 buns and the middle protein. In terms of what we're doing, the roadmap, we are in training mode right now. And you've received trainings on how to do the workflow in Epic and just your clinic workflow. So what that's looked like is really 4 sections. Workflow training on how to do this in Epic. That was on how to screen for food insecurity. So hopefully you've gotten that. If you haven't, you'll get a little refresher here. How do you do the workflow for eligibility referrals to CalFresh? And then the workflows for the R for H food pharmacy referral. And then the final workflow is the workflow for behavioral pharmacy referrals. And so the question is, why are we here today? Well, haven't we already done all the workflows? So we're here because we want to focus today on how to ask patients about food insecurity. You can just read any question off of your list, but how does it land on the patient? And how do you avoid the triggering situations where patients get upset or they're in front of their children, you're asking them about this. So there's an art to it. This piece is going to help you get beyond just the mechanics of which things to click, but the actual how, and that's our focus today. So I do want to do a review on some of those elements of that we did last time. So I'm going to ask, and feel free to come off mic if possible, or just chat. We want to increase CalFresh enrollment. But what is CalFresh, team?
The people who have insecurity of food?
Yeah, people who have food insecurity can access a program called CalFresh. It's extra money for food. It's really a government program that's been expanding, and it provides extra monthly income, $200, $400 per month, potentially for food. It provides longer-term food security because if a patient gets enrolled in this, they get this additional supplemental income to help them purchase the food. They can purchase additional food from our food pharmacy or from other places. So it's really, if you look at it, think kind of symbolically, it's cash for a healthy food. And then I know that your teams often want to know, well, what happens when I make that referral, right? When the MA pens the order, the prescriber makes the referral. This is review, hopefully, but I want to just hit it again. Do you all remember what happens and the turnaround time? Because MAs may wonder, or patients may ask MAs or prescribers. This will go to the eligibility department. We've already structured it. It's beautiful. You put in that referral, it goes to the eligibility department, and the eligibility team now has a list. And they're going to basically work that list and call the patients, assist the patient to get onto the CalFresh application, and then submit the application via the portal. There's a portal that comes to the county. So that's CalFresh. How about R4H food pharmacy? This is different than perhaps existing food pharmacies at your clinic, but we work with Dig Deep Farms. What does it provide, everyone?
Fresh produce delivered to the home.
You got it. Exactly. Erica, you got it. Whoever just said that. So it provides doorstep delivery. It's organic, what we call regenerative, because there's a big potential or a big focus on the soil health and the environment. And it's 16 weeks, a week, once a week for 16 weeks. That's 4 months of food to help food insecure patients. What happens with your referral? Do you all remember what happens? You get that referral into Epic. It goes into cyber world, right? Into the world of referral. So what happens to that? What can you tell your patients if they ask?
They take it 5 days for the application and then in 2 weeks they're gonna receive it.
You got it. I mean, you're pretty much, is that Gloria saying that? So Dig Deep is kind of like they're gonna call the patients. They're gonna contact the patients within 5 business days. They're actually gonna try 3 attempts. They're gonna go by text first. That's why you always wanna tell them, remember to answer your text. And then they're gonna call from a 510 number by phone. That's just text, because it's quick. And then the food will be expected to arrive within 2 weeks after enrollment. So if they text immediately, then within 2 weeks, the food should come. If they need a week before they text, then it's going to come 2 weeks after that. So just recognize that, the emphasis on reminding them to enroll. All right, so that was the review of the what kind of parts of the food insecurity offerings we can provide our patients. Let's go into the big questions. What is it? What is food insecurity? Why does it matter? And if we're going to be screening for it, what are the goals of screening? Which screening questions do you even ask to screen for food insecurity? So here we go. What is food insecurity? I would love to hear people's reactions, thoughts to this question. You can chat.
Food insecurity is one's inability to get food, either via accessibility or financial needs.
You got it, right? There's the access and the nutritious piece. Both Espinosa and Mo Campo sorry, I don't know your first names, have indicated that.
Oh,
so, Mila, that's right. Sorry. Mila, you knew all the answers last time. I remember that. So limited access to enough nutritious food to support a healthy, active life. This is the third piece that's often missing. People don't recognize this part. Okay, we got the access part. They may get the nutritious part, which is really important, but the healthy and active life is not always there. The piece is, this field has moved. Historically, we talked about hunger, and we just wanted the people not be hungry. So it's like any kind of food is good, just don't be hungry. You want Cheetos, donuts, Doritos, whatever, that's fine. Just make sure I'm not hungry. Food insecurity has evolved and really brought in the nutrition piece. And sometimes we'll hear people talk about nutrition insecurity in terms of its impact on health. But we actually want access, we want to address limited access, so we have access to nutritious food. And that's what our program is doing, to support a healthy, active life. Now, a lot of the prescribers on the call are also treating chronic conditions. And so our program does that too. It's a twofold piece. Thank you, Adrian. But you guys got this piece. Okay, so then let's move to the next question. Why do you even care about food insecurity? What's the connection to health? Why do you even want to find out if your patients have it? You're like, doctor, I'm just taking care of my patient with diabetes and blood pressure. Why do I even worry about food insecurity? What were your first reactions and thoughts be to that? So Dr. Jimenez says, yeah, no resources. If I don't have food resources, it's hard to sustain health. Yeah, keep on coming. Health is wealth and food can be a medicine. Love it. I love the tagline there. They need the tools to be able to make behavioral changes that will positively affect their health. That's coming in from Espinosa to prevent health issues. Yes. So there's a lot of different reasons. You guys are touching on a lot of them, right? And the one that I use when I'm usually talking to healthcare folks who have been thinking purely clinical and not some of these social determinants is I cite that food insecurity increases chronic disease. What you see downstream in medicine every day, if we address this more upstream with food insecurity, we would have less of the downstream stuff potentially. In fact, thank you, Manjot, for your piece on to ensure that they're able to afford and eat healthy food. Question is why, right? This is an important piece of important study. It tracked patients who had food security in red and then food insecurity in blue over time. And they found that if you were food insecure, your risk of developing diabetes was 200%. Why might that be? Why would someone who's food insecure have a higher rate of diabetes? Insulin resistance is correct. There's a piece around insulin resistance at the body, but why? Well, how would someone develop insulin resistance because they're food insecure?
Because the food is expensive too. The one is like a low carbs. It's very expensive to the patient can buy.
That's right. So it's what I'm hearing from Gloria say is it's the type of foods, and Phyllis is also saying the type of foods. Manjot and Ronaldin also junk food, right? It's cheaper, more available food, processed foods, and those foods have an impact on the body in terms of how we manage our insulin, and that's the piece that Dr. Jimenez was speaking to. So it's all of the cheaper of more available foods. If you're food insecure, don't have fun, and you go and dollars you get after that. You do this over time. You dose this every day, 3 times, 2 times a day for years. You're going to see a higher rate of diabetes. And this is just one chronic disease. There are other chronic diseases where there's a connection as well. So hopefully that helps at least answer one part of the question of why we care. I'm going to ask another. What else would be a reason for why we care about food insecurity for your patients? Myla, if you're speaking, I can't hear. Equity, fantastic, Dr. Jimena. Go ahead, Myla.
It's because, yes, it contributes to health disparities.
Health disparities, overall cost to society from Phyllis, right? Like we look at our patients individually, but we're also thinking as a community, how do we take care of folks? So it has an impact, especially on racial equity and health equity. And the numbers share, this is pre-pandemic, right? And some of this you have already seen, but I want to reemphasize. Overall, the population pre-pandemic, 11% of the patients of our community across the nation was food insecure. African-American communities, 21%, Latinx, 16%, white, 8.1%. You'll have Asians and Native Americans mixed in here. During the pandemic, everything shot up, potentially double, right? So this is a big piece for our communities, especially because their community health and all the CHCN clinics predominantly serve folks of color from these various communities. So we have the what, we have the why care. Now we're looking into, so fine, let's do this. If we're going to do this food insecurity screening, what are the goals of screening for food insecurity? What are we trying to achieve when we actually do food insecurity screening? And I'm saying this within the context of you and your patient, not necessarily for society, but you and your patient. What are you trying to do when you screen for food insecurity? Right. Dr. Jimenez is exactly right. You want to connect the screening to resources. What are some other reasons? A positive screen. What are the other goals that you're trying to do? When you do this, you're practicing this with your patients. I'm gonna offer some. So one of it is when you do this and you ask every patient, you normalize being asked about food by a healthcare team. Remember in the past when we didn't even ask about smoking? And now everybody asks about smoking, it's normalized. Or even intimate partner violence or formerly known as domestic violence. We just didn't ask that, but now we ask, we just normalize it. Healthcare is able to do, because we have access into people's lives, we are able to get into this with their patients. So we're normalizing it. We are also now acknowledging the role of food in health, something that we haven't done as much in medicine because we've been focused mainly on pharmaceuticals, but this is a key piece that everyone's recognizing. And then Dr. Alameda said it right. We're connecting patients to resources. Finally, we want to help the healthcare do something about the responses. It doesn't make sense to screen and have no pathway to help. So if we're going to do food insecurity screening, we better have the resources set up. And so that's what we have. So at the end of the day, you're bought in now. You're like, okay, Dr. Chen, I'm ready to do this. How do I even ask? And which 2 questions would I use? Is there science behind this? So I'm going to flash the following. This is a tool that we've developed in partnership with Bay Area Community Health. Each clinic has their own, but this is a laminated card. And this basically has 2 key questions at the bottom, and it's broken into 3 sections. And we're going to go into it later, but I want to just put this, telegraph it. There is a lead-in question. Don't worry about what this article is now. We're just going to go into it later. There is, but it's a 3-parter. There's an instruction statement, and then the real kind of the 2 questions. And this has been validated in the science, in the literature. High sensitivity, high ability to pick up patients who are food insecure. We're going to go deep into this, but I wanted you to know this is a resource that's ready to go at Bach. And it's available not only in English, but in Spanish and in Chinese. So that was part 2, the kind of details about food insecurity. This should be a review, part 3, it's key workflows. This is, again, more for prescribers without MAs and the MAs. The prescribers with MAs have a different workflow. So those who are here who are prescribers with MAs, just understand that, okay? This is speaking to your colleagues. So if you remember, the first step is screen and document food insecurity. Document the EHR, is there or is there not? And if it's positive, right, you want to add the diagnosis and pen and sign the order. Hopefully you've all tried this on. If you haven't, this is your chance to try it on this week. You want to, if they're positive, you pen the order for eligibility and you pen the order to referral for the food pharmacy. This is just food insecurity right now. We're not dealing with chronic disease. And then you can offer resources and reminders. There's a bunch of them where we're going to walk through the area food and meal resources, the website, Bay Area Community Cloud, the cloud where there's a bunch of handouts on there as well as the website, and then the reminder to enroll. That's the overall thing. So hopefully that's nothing new. In person, you have your card. Hopefully you all have the cards by now. And you basically can use the laminated card that's provided in the waiting room, or if the MA is holding it, that's fine. I believe you guys are holding it, but sometimes you just have to, if it's handed out in the waiting room or whatnot, then just request it back. But the key point is, however your clinic does the workflow, screen at every visit. So if you're an MA, have it in your pocket. Or if you're a RD or you're a wellness team member, a coordinator, have it ready. It's just nice and easy. If you're in telehealth, you're calling the patient, then you can use the laminated card because it gives you the lead-in and the instructions. Again, we're going to go into that in detail. I'm giving you the highlights. And then you can just enter it into the Epic area. And we're going to flash that through the screenshots. But it's all there. It's all built into Epic. What Epic doesn't have, you'll see down here, is it doesn't have the lead-in or the instructions. And again, you're wondering, what are the lead-in and instructions? I'm going to go deeper into that later. I want to just flash the workflow so you have a sense of where things stand. So you enter the food insecurity results into Epic. Do y'all remember how to do that? What's the first step when you're trying to find this? You're an MA, you go to
screenings.
There you go. And then And that's usually for MAs under the rooming tab. For the coordinators, it might be under a different tab, right? Not the rooming tab. So then what? You click food. Remember, you go down to select social determinants of health. You have the prepare tool, you don't do that one. You just go straight to the food one. You click that. That will populate these two questions. Sometimes in the literature, it's called a hunger vital sign. We're just calling it food insecurity screening questions, just in case you read about it. And then you just click for the patient after your laminated card, or if you have memorized your lead-in and all of that, you just go straight here. And if there's a exclamation mark, you don't have to worry about the numbers. Then it's a positive screen, and you're done. Any questions on that? This is what we want all MAs to do at each visit, right? As a team, we've partnered to say, this is what we're gonna do because food insecurity switches for many patients over the months. Is this unclear, unfamiliar to the MAs or to the prescribers without MAs, the wellness team folks or the coordinators? Okay. So then you can say, if they're positive, you can ask, would you like a list of food resources? This is something that you guys have built in. You have this area and food meal resources sheet. So ask your supervisors or your however you're organized, where this is. It should be in the S drive, but if you have it on paper, for example, and you want to print it out for someone in person, you've already come up with this. You're going to refer to CalFresh. Really, it's really a pending for those MAs and it's referral by the prescribers. You can just ask, oh, would you like help on getting extra monthly income for food through a program called CalFresh? If yes, place your referral. Order. This is all built in now, referral to CalFresh. This is, again, similar to what we did last time. CalFresh, boom, you're done. You can refer to the food pharmacy. Ask, are you interested in receiving 16 weeks of free organically grown vegetables to help get access to these fresh vegetables? If yes, the MA's pen, prescriber sign. Hopefully you've seen this recipe for health. Good to go. MA's pen, you got your CalFresh food pharmacy. It's a different one for you all. It'll say recipe for health, or recipe for health food pharmacy, and then prescribe for the prescribers. Are we clear on just the simple workflows there? Any questions? Hopefully the second time around, it's just, kind of hardwiring. You got to really practice it to make it real for you. The next section then is really where we want to go today. And this is the art of asking about food insecurity. Basically, how do you complete this screening without triggering patients? Because you may have encountered, I'm curious if you've asked this in the last 2 weeks and you realize, wow, that mother didn't want to answer me. Or you got a reaction that was fairly like, why are you asking me about that? Any quick reactions from folks, or has it been just smooth? Especially the MAs. These guys are doing it all day. So sometimes they become defensive, yeah. So then how do you get through that defensiveness? So let's move through this. So now I'm going to dive into the 3 parts of the food insecurity screen. And we're going to go through this in detail. I said there's 3 parts to it. And so the first part is our lead-in statement. We ask all our patients about access to food. We're not singling you out because it affects health. And we want to make sure you know about available community resources. Those are like the food pharmacy, CalFresh, etc., the area food and meal resource. Some people make the following statements about their food situation. And this is the instruction statement. So for each statement I'm about to read, please answer whether it is often true, sometimes true, or never true for your household in the past 12 months. 12 months. Not just last week, 12 months. Then you got your 2 questions, essentially, it's these 2 items. Within the past 12 months, you worried that your food would run out before you got the money to buy more. Second question, within the past 12 months, the food you bought just didn't last and you did not have the money to get more. What's the distinction? One is worry, you worried. The other is it just didn't last. The food didn't last. You ran out. If you are positive on so often or sometimes, that is a positive. That patient has some challenges with getting food. That's kind of like a positive screen. Question so far? I'm going to say this again. Okay, so Espinosa is saying, on occasion when offering programs, patients are in shelter and therefore have challenges with storage and what they can bring in. Absolutely. So there's different types of food strategies. And ours, we've said, is fresh produce. So not always the most appropriate for homeless patients, for example. And there have to be other approaches to that. So the lead-in statement, I'm just going to review it again because I want to make sure you guys get it. We're asking all our patients about access to food because it affects health. I'm not singling you out. And we want to make sure that you know about available resources. Questions about this? MAs especially. I know I'm just talking at you guys, but I want to make sure you guys have this lead-in sentence. You want to practice it, normalize it with all our patients piece. Okay, the instruction sentence again. Sorry if I'm being repetitive. Some people have made the following statements about their food situation. Sometimes you can say some because rather than have you, it softens it. Oh, some people, yeah, some people in my family. Thank you for signing in, folks. Please answer whether the statements were often, sometimes, or never true for you and your household in the last 12 months. 3 options, often, sometimes, or never true. So that's the instruction section, part 2. Then you have you just answer, you can go through these follow-up questions, the actual questions, right? Within the past 12 months, you worried, and you would just click, and if you're in Epic, they may say never true, fantastic. They may say sometimes true. Either if there's a positive screen, a 1 or 2, it doesn't matter if it's 2 2s, 1 1s, or a combination, that is a positive screen. You will get an exclamation mark. So just to make this real, we have some videos. And I want to ask for interaction here. We're going to watch a video. There'll be 3 series here. And I want you to pay attention to what was missing in this interview between a MA and a patient. How comfortable did the patient look? And what would you have done to make it better? Tell me if you can hear it.
And do you still?
Yes, no, can you hear it? I just want to check that. I'm assuming yes, but I want to make sure. Yes, okay, here we go.
And
Hold up. I click my thing, it goes elsewhere. One more time.
And do you still live at 123 Elm Street?
Yes.
Do you have any allergies to medications?
Nope.
And within the past 12 months, were you worried whether your food would run out and you didn't have money to get more?
What?
Okay. Reactions to that one. What did people notice? If anything, was anything missing? Was it comfortable? Was the patient comfortable? So Mila, you're right, not normalizing. She forgot the lead-in statement. Thank you, Erica. So it's really important, especially for the MAs who are going to practice. You don't want to forget that lead statement, right? She just went from allergies straight into this question, and the patient's like, what? Wait, you asked me about my allergies and where I live, and now you're asking me about what? So Ronald, right, there's no introduction about the questionnaire. So you guys are getting it. Let's continue. Here we go.
And do you still live at 123 Elm Street?
Yep.
Do you have any allergies to medications?
No, I don't.
Okay, we're almost ready for you to see the doctor. I just have one more question I'm supposed to ask you. Within the last 12 months, were you worried whether your food would run out before you got money to buy more?
Why are you asking me that?
You just saw a second clip. What's missing? Was the patient comfortable? What would have made it better?
some sort of lead statement into it.
Right, so continuing the
Like
lead statement.
we ask all our patients this question.
Yes, both you and Espinosa have it. Asking everyone this question is really important. Not just singling you out, we ask everyone. Any other thoughts? Okay. This last one, you'll see how it can go really flow really nicely. So let's just check this out and see how it's done.
And do you still live at 123 Elm Street?
Yes.
Do you have any allergies to medications?
Nope.
And within the past 12 months, were you worried whether your food would run out and you didn't have money to get more?
What?
Sorry, there's a repeat, guys. Here we go.
And do you still live at 123 Elm Street?
Yep.
Do you have any allergies to medications?
No, I don't.
Okay, we're almost ready for you to see the doctor. I just have one more question I'm supposed to ask you.
Repeating again.
Within the last 12 months, were you worried whether your food would run out before you got money to buy more?
Why are you asking me that?
Okay, now focus on this last one. Sorry about that.
Do you have any allergies to medications?
Nope.
Okay, so we're almost ready for you to see the doctor. I just have one last question. We're asking all our patients about access to food because it affects health and we want to make sure you know about resources.
All right. Sorry that you saw the first two repeated. Hopefully that just gave you another example to see, but that last one, you see how she opened with the "we ask everyone"? We're gonna watch other videos, but that's the key point here. So, main point, just to hit it over the head, we ask everyone. That's the key piece of the lead-in statement. It's normalizing asking patients about their food needs. So when the MAs are in clinic at 1 o'clock this afternoon, and you're beginning to ask your patient from whatever your list of screening questions, you want to lead in with the "we ask everyone this following question." So we have a few other scenarios. A patient now has screened positive, right? On the medical side, we say screen positive for food insecurity. In the chat or talking out loud, does this seem like it was comfortable for the patient, and what would have made it better? So here we go.
Here's the second statement. So within the past 12 months, the food you bought just didn't last and you didn't have money to get more. How often did that happen for your household in the past 12 months?
Sometimes.
Okay, so because you are food insecure, would you like a list of food resources?
I'm food insecure? What does that mean?
Here's the second.
So the key point here is, did you hear you are food insecure? This is common for us to do in medicine. Oh yeah, that patient's food insecure. Yeah, we have a bunch of food insecure patients. But when you're talking to the patient, you don't necessarily want to use that word. You are food insecure. Did you all catch that part? Can I just get a thumbs up, like yes or no? Did that make it in? You want to re-paraphrase. There's another way of talking about it, right? And we're going to get to there. But I just want to call out, it's easy for us in medicine. And then when we're seeing patients, oh yeah, you're food insecure. And the patient's like, what does that mean? What do you mean I'm food insecure? You mean I'm insecure about the food I eat? It creates all these questions, right? So even though we label things this way, you want to be mindful. How are we going to talk about it? So that's the question, right? And in the back of your mind now, how are you going to actually talk about someone who actually, quote, screens positive? Even now I'm using them, screening positive, right? So let's watch the next video.
Here's the second statement. Within the last 12 months, the food you bought just didn't last and you didn't have money to get more. How often did that happen?
Sometimes.
Okay, so since you screened positive, would you like a list of food resources?
Well, what does that mean? Did I do something wrong?
All right, guys, what did you see there? What's the key piece that made the patient uncomfortable?
She said positive.
Right, you screened positive, right? Well, did I screen positive for a blood test? Like, food insecurity sounds scary. Ronald, you're absolutely right. Screening positive? What? You're just asking me about my allergies, and now you're saying I'm screening positive about food? Oh my gosh, what does this mean? Right? We're increasing anxiety in medicine, especially the MAs, and when you're setting the table for your provider, you're wanting to decrease anxiety and create a smooth process. For the wellness coordinators and the other folks, behaviorists, you want to be able to ask it in a way that doesn't amplify things, right? So be careful of the word choice. So the point is, avoid you screen positive, right? So main point, again, just to hit it over the head, you want to say, because you don't want to say because you are food insecure, and that's because it's stigmatizing. Food insecure, yeah, it's kind of hard to hear. You don't want to say you screen positive because it's jargony or it sounds scary, right? Screen positive is what we say in medicine, when we're talking internal to each other. We have a bunch of food insecurity and positive screens and whatnot. But you don't talk about that to patients in this way. So then you're saying to me, okay, Stephen, like, what am I supposed to say? All right, this is my natural way of just talking. So now what do you want me to say? So here's what we got. Let's try this on. Let's watch this one and see how this goes.
So here's the second statement. Within the past 12 months, the food you bought just didn't last and you didn't have money to get more. How often did that happen?
Sometimes.
It can be hard to eat healthy on a budget. Would you like a list of food resources?
Thank you, that'd be great.
So what was different about that? And I'm happy to play it again if it'd be helpful for folks, because I know this is fast.
She's gentle with her words, or how she asked the question.
Right. So there's, this gave the patient power. She's gentle. There's a style. Is there any particular phrase you picked up? Let's try it again.
So here's the second statement. Within the past 12 months, the food you bought just didn't last and you didn't have money to get more. How often did that happen?
Sometimes.
So sometimes, right?
So here's the second statement.
Sorry, I was trying to pause it.
Within the past 12 months, the food you bought just didn't last and you didn't have money to get more. How often did that happen?
Sometimes.
It can be hard to eat healthy on a budget. Would you like a list of food resources?
Thank you, that'd be great.
Right, so it's a positive response sometimes, right? So she goes straight to, it can be hard to eat healthy food on a budget. That's essentially what food insecurity is, right? So you're not saying you're screen positive. So basically you can use the phrase, it can be hard to eat healthy foods on a budget. It sounds like it's hard to eat healthy food on a budget. Softer way of saying food insecurity. It's hard to eat healthy on a budget, and then the piece is, well, we can connect you to food resources and maybe make a referral to our food pharmacy in CalFresh. Interested? Let me get some feedback. This is not an easy thing necessarily to shift into because we're so efficient, you're food insecure or not. It's hard to eat healthy on a budget. How does that land for you all? MAs, wellness coordinators, prescribers? Something, does it seem too hard to do? Not natural, or actually not too hard. I can adapt. Can relate to it. Thanks, Adrian. So percolate well on this one. Okay, we'll keep on going. I'm going to put it all together right with this video. So you're going to see that from the beginning to end, a possibility of how you can practice it.
Do you have any allergies to medications?
Nope.
Okay, so we're almost ready for you to see the doctor. I just have one last question. We're asking all our patients about access to food because it affects health and we want to make sure you know about resources.
Oh, sorry, guys.
Some people make the following statements about their food situation. So I want you to answer whether each statement was often, sometimes, or never true for you and your household in the last 12 months. So here's the first one. In the last 12 months, were you ever worried that your food would run out before you got money to buy more?
Yeah, I guess.
And to clarify, what I mean is in your household, was it often or sometimes true in the last 12 months that you were worried about food running out before you had money to buy more?
Oh, sometimes.
Okay, and here's the second one. Sometimes people say within the past 12 months, the food we bought just didn't last and we didn't have money to get more. For you in your household, how often was this often, sometimes, or never in the past 12 months?
Sometimes it happened.
So you see how she asked it, right? What did you all notice? You just saw how she asked it. What did you all notice? Personalize it. Can you say more about that, Dr. Jimena?
It wasn't just reading off that cheat sheet. It was more like putting it in context. Okay, your household, was it more sometimes? And then she also opted obviously with the never, just in case it's not applicable. So instead of having the whole statement as is, as it's written out, she rephrased it where it's more like the patient gets a choice, that some sort of power for the patient to declare whether or not, okay, is it applicable to me or not? It's
Right.
not jarring.
We have that card for you all, and there's a sequence, 3 steps. And Dr. Tester here switches it a little. The point is, as you practice this, you will develop your flow, but you need to practice it. You want to get the fundamentals, and then you can personalize and contextualize. She said all, right? We ask everyone. She kind of said the statement and then went into, hey, is this happening for you sometimes, often, or never, right? Kind of the 3. She kind of sandwiched it that way. But you're going to make it natural for yourself. But you want to know the fundamentals. There is a lead-in. There's an instruction section. She repeated it. And then there's the actual statements. She went statement, statement. Here's the first statement. Is it the frequency often, sometimes, or never? She did the second statement, often, sometimes, never. There's different ways to do it. But this is just one way. You need to make sure it rolls off your tongue comfortably.
Do you have any
pause this
allergies
one and then move to the next. So the main point is you're not alone. And then she's still had a need for healthy food, right? We're trying to get there. So this last video is about connecting patients to resources. And notice how she does that. Once someone shows that they're, quote, positive, right? We won't say that, but they're essentially needing help because it's hard to get healthy food on a budget. This is how she does it.
It's hard to eat healthy on a budget. Would you like a list of food resources?
Well, what do you mean? What is that?
Well, we're trying to connect food to the people who need it the most right now. A lot of resources are free. You don't need to give any personal information. Would you like to know more about how to get free food?
Yes, please.
So it's just about, the whole purpose of this is identify who is screening positive, who is food insecure, who's having a difficult time getting access to healthy food on a budget, right? And then connecting to the resources and making it safe for them to do so. So food pharmacy is one of your resources, both the ones at Bay Area Community Health that are existing or any other food programs at your clinic. And then certainly the Recipe for Health food pharmacy, where it's just going to deliver the food to their home and is regenerative food on a weekly basis for 4 months. And then certainly CalFresh. So the summary of what you say, just to hit it again, we are asking everyone, not just you. We can connect you to free food resources such as the food pharmacy, MAs with pen, prescribers would place the orders, or prescribers without MAs. And you always do CalFresh, you want to offer it. Some patients will say, oh, I already got it. Then you don't have to pen it. If they already have it, no need to pen it or place the order. Or they say, I'd like to learn more. And then you pen it. The eligibility team will follow up. Your role is to just identify the patients and get them support. So I just explained that part in terms of the role, right? That's your role. What are your questions? About 10 minutes to think through this together. Go for it. Questions?
The patient, they don't qualify for CalFresh, like they don't have, they know I document here, they don't qualify.
Right. So the question is, hey, there's 2 things under that question. Do they qualify or not? Are they undocumented? Is that going to be a barrier? This is why this is really important about roles and responsibilities. Number one, the question of if they qualify or not, you don't necessarily need to make that determination as the clinical staff, the MA, the prescriber of that MA, whatnot. If there's a need, you can have the eligibility team figure that piece out with them, because otherwise that becomes a whole nother 10-minute visit, right? Just, do you want to learn more and get information? Our team will follow up with you. The second thing is really important. Historically, in the last few years, we had a different environment around undocumented, and the previous federal administration was creating difficulties. And so there was a lot of fear in undocumented communities around something called public charge. That is no longer the case in the current state. That is gone. There's no concern around being prosecuted for public charge to get access to these resources. People may still be feeling that though. So you want to be, you don't have to push CalFresh, but you can say, hey, things have shifted now. Accessing these resources does not affect your immigration status. Other questions you have? I'm going to keep on going and just say, we have a fog of care resources. We have not finalized the at-a-glance document. We're finalizing that. Just, we will have it and send it to your teams, and then it'll be on the S drive. And we're developing our website to actually hold all of this for each clinic. But you will have in the fog of care, because MAs are busy and you get this training, you're like, okay, I want to do it, but I forget. We have a one-pager that just tells you how do you do it, what are the steps and the resources. It's a two-pager really, one back-to-back is a one-page. That's pretty much the training. We have 8 minutes to go over any other questions, or to even practice it if it would be helpful. To take a volunteer, we can walk through the questions. I want you all to really come out of today's training and being able to answer all the questions you have, and then to try it on. And feel confident trying it on.
Doctor, then when we enroll the patients when they positive, we send both refer, no matter what, CalFresh and the recipe.
There's a lot of feedback. I had a hard time hearing that, Gloria.
I think if Cece mutes or turns her mic off, then it'll be fine.
Okay, so Gloria, if you can turn your mic off while we wait for you to do that. Other questions? I'm happy to go back to any slides. Yes, perfect.
Okay. Then when we screening the patients, if they positive, we send, no matter what, both refer for recipe, for health and the CalFresh. And then the refer department is gonna be checking for everything. Is they qualify or not for CalFresh, right?
The question is, if you get a positive screen, do you refer to both food pharmacy and CalFresh? The answer is yes. Now, if they say no, they don't want it, then you don't have to, right? But in general, you want to pen. The MA's role is, if you're an MA, you get a positive screen, right? You don't talk to patients that way. If it's a positive screen, you just automatically pen the order for the provider, and that would be for the food pharmacy and for the CalFresh. Normally, though, before pending, I usually ask that intermediary question, because the patient may say, oh, I don't want it, and then you don't have to pen it, right? So I think it's helpful to, and I'll pull that screen up again, just to walk through that specifically, because we went over it quickly. So for example, this is in that section on workflow before the art of asking. So let's just talk about CalFresh. Someone screens positive on CalFresh, you can ask them, right? Would you like to get help on getting extra monthly income for food? If they're like, no, I'm afraid of the federal government, I don't want it, then don't pen, right? It's always good to get permission. And then with the food, are you interested? Oh, it sounds like you're having a difficulty getting access to food or getting healthy food on a budget. Are you interested in receiving 16 weeks of free organically grown vegetables to increase access to these fresh vegetables? If they say, no, I really don't like to cook, I'm homeless, I'm whatever, then no need to pen or sign the order. Does that answer your question, Gloria? Okay. Other questions?
Thank you.
I would love to hear from MAs. I know it's tough sometimes for the MAs, especially if you're in a big room, but you guys are so close to the patients. You all have relationships with the patients. What questions are coming up for you all? And while you think about that, I see that Amelia put a question in. Is there a place where you can put patient decline food resources? We don't have that in the electronic health record. Just don't put it. There is a decline question on the question around food insecurity, those two questions. If this says, I don't want to answer it, then you can put decline. But we currently, out of the box in Epic, don't have that. Thanks, good question, Amelia. MAs in particular, any questions? Because you'll be doing this so often, hopefully it becomes super easy. But in the beginning, it's just getting over that hump. How about the wellness prescribers? The wellness prescribers without MAs.
I have one question regarding the group med. So are we currently doing that, or we are just following just the food insecurity, those two, Call Fresh and a Recipe for Health, those two only?
So today's training is about just the food insecurity piece, but the trainings before were about actually the group. And so group still exists. Like if you want to get the patients into group, into the Recipe for Health behavioral pharmacy group medical visit, because they have a chronic condition, fantastic. But you don't really refer a food insecure patient if they're only about food insecurity, they have nothing else, no chronic condition, nothing. You don't really refer them to the group. This training is about those patients that are food insecure. The MAs are all over it. Prescribers that MAs get trained on it because they don't have an MA to help them. But the prescribers with MAs and prescribers without MAs here in today's training, don't forget, you have the access to referring to them to the group. And if you refer them to the Recipe for Health group, you don't have to write the prescription. Just remember that for the food. Because they're gonna, if you refer 50 people, 10 of them may show up to Erica on March 4th. Erica Huang's your provider. She will make sure, she and her MA team will make sure those 10 people then get a referral to food. We don't want to send the food, we don't want an automatic food referral with the group people, because some of those patients may not come to group. Does that make sense? So today's focus is just to get everyone comfortable about the food insecurity piece, because there's MAs in the room. But the prescribers and prescribers with and without MAs, you have access to the Recipe for Health group as a separate referral. And you would then essentially cancel the MA's pending request. Say, Sangeeta, you're my patient. Let's just play this out. And my MA, say one of the MAs screens you for food insecurity, but then I also see that you have diabetes and you want to get into a group. I won't sign the food insecurity, or I won't sign the referral to the food pharmacy, because I've now made the shift. I want to get Sangeeta into the group. So that's a small nuance, but an important one.
Okay.
More questions on that? I don't know if that was clear.
No, I got it. So one more thing. So if they are interested in, like, if they have a diabetes or hypertension, I can go and refer them, but they should be interested to participate as a group. Like the 16 weeks, they should be, it's like a Zoom, right? Zoom class kind.
It's a Zoom group, right?
So they will get a Zoom group and food is going to be still delivered to their door.
That's right.
If they miss any classes, so that means the food is not going to be delivered?
Once they come in a group and show up in group, the food will come anyways.
Okay. If they showed up for 10 classes, if they don't show up for the rest of the class, they
The
will
food
still get it.
Yeah.
Okay. Okay.
Yeah,
Got it. Thank you. Yeah.
You're welcome. We're at time. Any final questions?
One last question, Dr. Chen.
Sure, Myla.
So we have also Project Open Hand.
That's right.
Patients. So the goal of this program is to really address food insecurity, right? So even though there's Project Open Hand already delivered to their door, we can still offer this program.
It's up to you, absolutely. You get to choose if you want if the patient needs Project Open Hand and they need Recipe for Health and they need the Bay Area Community Health, on-site pharmacy, you guys know the patient best. What I would just say is know that there are many resources, but you want to spread it to as many people as possible. So sometimes, say if Project Open Hand has only a few openings, and you don't want to utilize it on everyone. Recipe for Health is fairly robust. We can accept all comers. They can have other support or they cannot. Great question. We're at time. I'm happy to hang out if you have other questions, but feel free to leave. Thank you all for your attention and your great questions. And we're open to feedback. If I can make this better for you all, that's what I'm trying to do. Thank you. Thank you all.
Thank you.
Thank you.
Dr. Chang, I have one question.
Sure.
After, when they in the class, example, we enroll in March, right? And then we still continue, and then we enroll one patient in April. Is this classes like a cycle, or anytime they can go to the class?
Great question. So again, today's training was not on the group, but since you're asking about the group, I'll talk about it because I didn't want to confuse the MA since they're not really responsible for the group. But I will talk about it because you're asking. The group, people, it's a cycle. They can join at the beginning of each month. So there's always new people joining every month, and then there's people graduating every month after the first 4 months.
Okay.
So you don't have to wait 4 months and then get another group in and wait 4 months. No, it's a rolling admission.
Okay.
Adrian's asking, screening is only for Alameda County patients. That is a question. This is certainly, we're doing this right now at Liberty. So at Liberty, we are doing this. And then I think that'll be a larger systems level question after we get this up and going. Other questions? Thank you, Adrian. Okay. Thank you all for your time and attention. Go to it, screen those patients, get the food to them. Appreciate everything.